Hey everybody, Dwayne Howerton here from the Office of the Medical Director. In alignment with the vision of OMD, which is to be an integral member of a high-quality, evidence-based and outcome-driven mobile healthcare system, along with our mission to build quality into the mobile healthcare system through the enrichment of clinicians, we are super excited to bring you this update to the clinical practice and treatment of out-of-hospital cardiac arrest with the establishment of ECMO-facilitated resuscitation in our service area at established ECPR centers. There are no conflicts to provide at this time. All right, so what are we going to talk about today? We're going to review some evidence-based research around ECMO-facilitated resuscitation and also kind of present the history of ECMO and its development through time. We're going to provide the purpose of establishing ECPR centers in our service area and discuss the protocol surrounding the inclusion and exclusion criteria for patients that will be taking to these ECPR centers. We'll talk about the implementation process and definitely talk about the goals of resuscitation. Definitely trying to create that environment of a stable resuscitation and things that need to happen before we move a patient towards these ECPR centers. We'll present also the outcome and balancing metrics that will describe success as we move through this project. All right, let's dive right in with a little bit of history. In the 1940s and 50s, membranes were developed that allowed oxygen to pass through it. So these membrane oxygenators were developed in the laboratory and blood was allowed to pass over them, and it showed that they could transfer oxygen through the membrane into the bloodstream. In 1953, they were able to use these artificial oxygen perfusion support systems to actually perform the first successful open heart surgery. And over this time, proceeding into the 1970s, was really the development of the heart-lung bypass machine and its use in the OR. With the development over time into the 1970s, ECMO really found its place in the treatment of ARDS within the adult patient. The following year, we would have the first successful case of ECMO support in a young pediatric patient. Then in 1975, we had the first successful case of ECMO being used to support a neonate who had meconium aspiration and respiratory failure. And in 1976, we had our first case of ECMO being utilized during a CPR case in a patient with refractory cardiac arrest. While initial studies cast some doubt on the use of ECMO in cardiac arrest, it was into the 1990s where ECMO became the standard for ARDS treatment in pediatrics and neonates. It wasn't until the 2000s that ECMO actually became the standard of practice for treatment of adults with ARDS. And if you want to say that 2009 is fairly recent, that's when ECMO really found its place as a standard of care in the treatment of ARDS in patients. Well, all of that to lead us to where we are today with some evidence-based use of ECMO in the treatment of cardiac arrest. Dr. Yiannopoulos and Bartos out of Minneapolis performed the ARREST trial, which really looked at the use of ECMO in the treatment of patients who were found in refractory VFib. The ARREST trial enrolled 30 patients into its study. The study was actually stopped early because there was significant survival benefit observed with the use of early ECMO in these cardiac arrests. There were 7 survivors. 1 of the patients received standard ACLS care. 6 of the survivors received ECMO-facilitated resuscitation. And the primary outcome just looked at survival to discharge. And in that case, those were the 7 survivors were found. The secondary outcomes looked at survival to 3 to 6 months. The individual who survived to discharge in the control group, meaning that they received standard ACLS care in resuscitation, did not survive to the 3 or 6 month mark. All 6 of the survivors that were discharged who received ECMO facilitated resuscitation have survived to the 3 to 6 month mark. And here's the exciting news in regards to the survivors who received ECMO facilitated resuscitation, is that their cerebral perfusion category score, meaning their neural functionality upon discharge, all have improved into the 1 and 2 category, which represents good neurologic function. Some more evidence to support this project of initiating ECMO-facilitated resuscitation within our service area comes again from Bartos and Yiannopoulos up in Minneapolis. as they looked again to individuals who were transported to the hospital, were admitted to the hospital, and then discharged neurologically intact. There were 100 patients enrolled, 83 achieved admission. Of the 83, 40 were discharged, functionally intact with the use of early ECMO in their resuscitation process. So the history, the evidence, all brought together a couple years ago, the discussion at the Emergency Physicians Advisory Board in regards to the implementation of a ECPR or cardiac resuscitation center within our service area. Supported by EPAB, we put together the ECPR task force, whose members come from the 4 primary hospital systems within our service area. Currently, patients found in shockable rhythm occurs on average 150 times a year in our service area, with about 24% of these patients surviving to discharge with minimal effect on neurologic function. While local survivability is around the national average, it is well below the survival produced within the arrest trial. There is an identified opportunity for us to increase not only survival, but survival with good neurologic function through the establishment of pre-hospital treatment protocols, including transport to specific ECPR-capable facilities within our service area. So the purpose of this task force was to establish a program for the treatment of out-of-hospital cardiac arrest patients with ECPR in our service area. On the graph here, you can see our ventricular fibrillation VTAC arrests that occur within our system and the volume that has occurred over the last 5 years. You can see that we have a decline in our survivability and more significantly a decline in the survival with good neurological outcome, thus supporting the reason why we are doing this today. All right, let's talk about the type of patient that's going to fit into the inclusion criteria of this new protocol and treatment plan. First of all, adults. Second, presumed age of 18 to 60. I know that the arrest trial looked at 18 to 75. We'll open that window at a later time, but currently our window is going to be 18 to 60, presumed age of an adult. Next is that first recognized rhythm. Is it shockable? Is it VFib, VTAC? If it's shockable, they're eligible, okay? So we'll talk more about that when it comes to like AED, bystander, and all that stuff. But if the first rhythm is shockable, they're eligible. Next is body morphology. They have to fit within the mechanical compression device that's being used. We're going to be transporting these patients, most likely with lights and sirens, because this is a time-sensitive disease, and getting them to the ECMO center is going to have a time window. And that time window is going to be about 30 minutes. So from the time that you have first medical contact with this patient, initiate your treatment plan, and get them to the emergency room is going to be about 30 minutes. All right, now that we have a patient that we've identified, age 18 to 60, adult, first shockable rhythm, or the first rhythm was shockable, they're eligible. They fit into a mechanical compression device, and we're within our 30-minute window to getting them to the ECPR center. What are the things that are kind of going on? So let's get into the procedure, right? So we've identified that patient. What we're going to do next is we're going to follow that adult cardiac arrest protocol until stable. And we'll talk a little bit more about what stable resuscitation looks like in just a few minutes. All right, next, we want to notify the closest ECPR center of a code ECPR. This is much like your STEMI alert, your stroke alert, your trauma alerts, okay? Code ECPR on your handheld at the bedside to the center to get them activated and things in motion at the receiving facility, all right? Now we're going to go through preparing our patient for transport. And that goes back to the stable resuscitation items that we'll talk about next. During transport, continuous monitoring is absolutely vital to the success of this program. No matter if you're going to an ECPR center or to another hospital, monitoring your patient, that continuous monitoring and route of the things you have in place are going to be important, right? Full patient report during your transport to that receiving facility, that receiving ECPR center. And obviously, once you get there, you're going to remain with the patient in the ER just to assist with the mechanical compression device's operation and retrieval once they get the patient on ECMO. All right, here's the goals of a stable resuscitation. All right, in the process, we're following the adult cardiac arrest protocol. Okay, we're going to be providing compressions with the mechanical compression device. We already know that these devices have a tendency to walk on us. Placement time is important. Using the two-step process and placing the mechanical compression device is vital in reducing that pause time and compressions. Okay, but it also must be monitored once in place. If it should walk, it has to be corrected so that it's providing adequate resuscitation compressions. Rapid shock. Every 2 minutes we need to be evaluating our rhythm, because if it's still shockable, it still is eligible to get shocked. So we need to be providing electricity when we identify that we have a shockable rhythm. So Q2 rhythm checks are going to be important, and no marathon CPR with that mechanical compression device. Your advanced airway. King airway is fine, endotracheal tube is fine, but it has to be monitored. Good end-tidal CO2 will be important. Adequate ventilation of these patients during the resuscitation, transport, and delivery phases are going to be vital to the success of the program. Obviously, access. Got to have that IV, the IO in place, patent, so that you can infuse fluids and deliver your drugs that are required within the adult cardiac arrest protocol. Your epi, your amiodarone. Should you achieve ROSC, you may need to be delivering that Levophed to support blood pressure in that post-ROSC phase. Remember, still within that 30-minute first medical contact to ECPR center window, let's go. Let's get there. Let's get this patient to ECMO. If you're no longer there, go with your family choice as far as destination or the closest full-service hospital. Okay. It's okay if stabilization takes too long and you fall outside the 30-minute window. Remember, a solid, focused resuscitation on scene is still a patient's best chance of survival compared to us rushing them to an ECMO center. Okay. Also, remember you're doing those Q2 minute rhythm evaluations, and after that third shock, maybe changing the vector of your pads could be the difference. All right, to reiterate again, we've identified a patient that meets pre-hospital inclusion criteria. Age 18 to 60, adult. They fit in the mechanical compression device. We're within that 30-minute transport window to the hospital. Once we get to the hospital, additional evaluation as far as the appropriateness to put the patient on ECMO will be done. The first thing, they're going to draw an ABG. That ABG will be run right there in the room, and results will be given to the physicians who will be doing the ECMO cannulation. If the PaO2 on that ABG is less than 50, then that's a hard stop to not proceed with cannulation and placing the patient on ECMO, as is if the lactate is greater than 16, along with a pH less than 6.9. If any one of these three factors are in place on the evaluation of the arterial blood gas that they draw upon your arrival, the patient will most likely transition down the path of a traditional ACLS guided resuscitation, and ECMO cannulation will not be done. We want you to be aware of this. We want you to know this so that your efforts pre-hospital in getting this patient to them isn't felt like it's in vain. Okay, there are some other criteria that can have to be evaluated prior to placing the patient on ECMO. With any initiated program, it's important to measure outcomes. And so we do have some performance measures that will be looked at in regards to this pilot program with ECMO CPR. This will be evaluated by that ECPR task force group, and continuation of the program will be primarily based around these performance measures. So there are some pre-hospital ones, right? So arrival within the 30 minutes, appropriate protocol initiation. Are we identifying the correct patients and bringing the right patients to the ECMO center? Along with pre-hospital notification to the receiving ECPR center prior to transport. That's important. Activation of the team is vital. There will be a lot of members of the team. There'll be a group taking care of the patient's airway, another group taking care of the patient on a whole. There'll be another entire group who is responsible for the ECMO cannulation and establishment of the patient on the ECMO pump. So there'll be a lot of people, and they need to be activated early so that they can arrive and be prepared and ready for your arrival. There's also some hospital performance measures that will be looked at. One of the big ones will be average time of first medical contact to ECMO cannulation. We'll also look at patients that meet the exclusion criteria that kind of fall out of the ECMO treatment plan, and then we'll also want to know about their average length of stay in the hospital. And I think these right here are the big ones, right? These are the system measures that we'll be looking at in regards to discharge from the hospital, neurologically intact, after receiving ECMO-supported or facilitated resuscitation in the hospital. We'll also be looking at our overall hospital survival rate, but the big one for us truly is survival to discharge, fully neurologically intact. All right, with every performance measure to see how well you're doing, there's also some balancing measures or risk measures that we have to look at. New program, what are we seeing as it relates to our goals of resuscitation, or those goals for a stable resuscitation prior to moving, okay? Are we meeting the goals, or are we moving too soon? That's something that we have to look at. Also, transport CPR is still not as good even with an MCD. So some of those things will have to continue to be evaluated. Are we missing opportunities with rhythm checks? If we're missing defibrillations, we're not assisting the patient in really our goal for them to survive this event. And then there's the overt triage, right? This protocol isn't for everyone. It's for a specific group of out-of-hospital cardiac arrest. And we need to assure that we are meeting that particular group's needs and not applying this transport to a ECMO center for all patients. All right, I know that we're just getting started with this program and I'm excited about it, and it's just getting rolled out, but doesn't keep us from looking into the future of what this could be down the road. Right now, our age criteria is pretty tight, 18 to 60. The arrest trial looked out to 75, so there'll be the potential as we look at our performance measures and increasing that age and pushing that age limit out further. Also considerations for other types of rhythms, not just shockable. Potentially PEA could be a good rhythm that ECMO facilitated resuscitation could assist in increasing our good neurologic outcome status. And then the ultimate would be field application of ECMO facilitated CPR. This is taking the ECMO to the patient and not the patient to the ECMO. So some exciting things to come as we evaluate the progression of this program in our service area. As I mentioned earlier, the ECPR task force was made up of the 4 hospital systems within our service area. We have Baylor Scott & White, we have John Peter Smith, we have Medical City Fort Worth, and we have Texas Health Fort Worth. Currently, all of them are working on their ECMO facilitated resuscitation programs, and Baylor Scott & White is live and ready to receive qualifying patients as we speak right now. So their program is ready to go. We've done several mock runs with them. They've performed very well through the mock runs, and they are excited to get going and receiving patients that meet our inclusion criteria for this program. The other 3 hospital systems are in development projects with their ECPR, ECMO facilitation within their ER setting at this time, and once they get live with that process, then we will let you guys know that they are then open. We will put this in the specialty receiving hospital list so that you're aware of that, and obviously provide communication as other hospital systems come online in support of this project. All right, almost done here. We've made it to the take-home points, and we really want to put an emphasis on this because once we've completed this, you are set up to identify patients that meet the inclusion criteria and get them to the ECPR centers. So the biggest one of all, do not rush. Remember, slow is smooth, smooth is fast. I know we're operating within a time window, but do not rush. We have to get this right, okay? If you can shock the first rhythm, we want you thinking ECPR center. Now, if that first shock changes your rhythm in any way, say to asystole, then maybe the closest PCI center is the appropriate place for you to go to, okay? We want you to activate the code ECPR from the bedside. So if you have that first rhythm identified as shockable and you're progressing through your stabilization within your resuscitation, activate code ECPR right away from the bedside, all right? Achieve your goals, then think transport. And remember, we talked about those goals of adequate mechanical compressions being applied by the device with it being monitored for walk and those kind of things that can happen, that you've monitored your rhythms, you're providing the Q2 shocks as needed per the identified rhythm, you have your advanced airway in place with adequate ventilation, meaning you got 4-phase waveform on your end-tidal CO2, you have your access IV or IO, and you're administering your drugs, epi and amiodarone, per the cardiac arrest protocol. Okay, watch. You got to watch your MCD. You have to watch your end-tidal CO2. You have to monitor your rhythm throughout this whole process, including transport and delivery to the ECPR center. Okay, don't forget, once en route, give that full report on your patient. So here's kind of the tough thing, right? Addressing the family in regards to the actions being taken with their loved one who is in cardiac arrest. So kind of put this script together to kind of help you guys out a little bit in regards to communication with the family about what you're doing, what your next steps are going to be, and where you're going to go, all right? So in addressing the family, be direct, let them know the things that you are doing, you're providing the necessary treatments, and that you're going to continue those treatments during transport to the hospital, okay? And that you're going to be transporting to a cardiac resuscitation center, which currently is Baylor Scott and White, to continue treatment that will give their loved one the most significant opportunity at survival. So use the script, use something similar, but definitely the communication with the family will be important. Should the family disagree and request to go to another hospital, we have to honor that request, and so you may need to call Baylor back to deactivate them. Should the family say, no, I want my patient to go, my loved one or family member to go here. All right, I know there's going to be a lot more questions asked than this, and I'll definitely reach out if you have further questions with that. But when can we start? We can start now. Okay, so you've reached this point in the presentation, your next shift, you are live to go forward with the initiation of this protocol and treatment plan and transport to the ECPR center, right? Well, what if MedStar provider or what if an FRO provider doesn't know anything about this? They haven't even seen this yet. Well, everyone should have at least received the Medical Directive that outlines the inclusion criteria and the procedure around this and the items that we've talked about today. So have that conversation and proceed, right? Does a bystander AED count? Does bystander AED count? Yes, it does. Okay, so if the bystander AED advised shock, it's a go. Especially if you work towards your goals, you'll have the opportunity to evaluate the rhythm within the cycle of your resuscitation care, and thus will be able to assure that we were in shockable rhythms along the way. So I'm sure there's going to be a lot more questions. Send them our way. All right, that concludes this presentation. Further questions, shoot us an email, contact me directly. Happy to answer those. But as it stands right now today, as you have watched this presentation, your patients who meet the inclusion criteria are eligible to be transported to an ECPR center. The current ECPR center that is online is Baylor Scott and White, All Saints. Thank you guys so much for everything you do. thank you for being part of innovative medicine that is going to change the lives of patients that you touch, and the application of ECMO facilitated resuscitation for patients found in shockable rhythms. Y'all have a great day. Be safe.